sorry not to be able to speak French, but I'm not skilled enough to speak in a relaxed manner, and therefore I would like to follow the tradition and speak Italian. I'm Carlo Bonapace. As Enrica introduced me, I work in Turin, which is close to where we are, in Piedmont. I have to switch to Italian, sorry. And I use Genius system. I've been using it for a couple of years. I was an MBT orthodontist. I was convinced, and I had a close relationship with Cloughy and Bennett. And then I was enlightened, and Damon enlightened me in 2008. And then I started using other self-ligating system up to Genius. It is very interesting to see the discussion in orthodontics between extracting or not extracting. This goes back to the beginning of orthodontics. And actually, it has been a sort of pendulum in the different historic times. There were a period where we extracted more, like Tweed and Begg, in the 50s and 60s, and then in the 70s with settling rickets, we started non-extracting. In a period of balance, however, now we are in non-extraction era, and we basically propose non-extraction philosophies. Furthermore, with the passive self-ligating system, and Genius is part of PSL philosophy, this philosophy advocates for arch development, which is the core of the PSL system, and therefore it is said that extraction are rarely required for space purpose. Therefore, we can obtain arch development in space thanks to self-ligating system. And this happens because we have a different pattern of tooth movement that is induced by reduction in resistance to sliding, so reduced friction, using low friction and low force biomechanics, using very light forces. And therefore, let's see here some pictures, and we see what we mean by arch development. On the left, we have a constricted arch with some crowding, and as we proceed with the therapy, the arch changes form and develops, and we gain space. Another fundamental pillar in the philosophy of PSL, passive self-ligation, it's disarticulation. To have arch development in a very effective manner, we have to have the two arches not in occlusion. We have, therefore, to impede that occlusion blocks the movement. D-gainer. D-gainer is a special arch development tool that is used in kids during premolar eruption, and it's very effective because it helps us in gaining space, and it uses also the Frankel effect, because you see that the brackets are only on incisors and molars, and there is arch with springs that push, of course very light forces, but they don't only push, but also move from the cheek, the muscle from the cheek, and therefore we have the Frankel effect that develops the arch. So the buzzword in a passive self-ligation community is extract for the face, not for the space. And it's a rhyme in English, which means that you have to extract only if you need, because you have a protruded face, but not because of crowding. Clearly, this has to be a very cautious approach, because you can run into serious troubles if you misdiagnose the case and therefore the treatment in a case of severe crowding. Therefore, with the help of some clinical cases, I would like to share with you some critical elements about the decision when to extract and when not to extract in case of doubt. And let's see together what makes us decide whether to extract or not. Let's start with this young boy. He's just 11 when he comes to our office for the first time. These are the pictures, extraoral picture. You see face, profile, the front view, and the lateral view. And you see the two arches. You can see from the occlusal view how constricted the arches are. We lack space. And I would like to show you the pictures of the patient once again, so that when we consider how to treat the patient, you will have more data. We see the head film and the OPG. We see immediately that we have high angle tendency. It's not really hyperdivergent, but it's a high angle tendency, slight class 2, slight incisor retroinclination. And as you see from the OPG, we have upper canines that are slightly impacted. What is the treatment plan? Of course, it's arch development according to the self-ligating principles. We start with the D-gainer at the beginning, with the springs, light springs, and then we progress with the wires up to 18 by 25 nitine and 90 by 25 in beta titanium. And you see titanium, and you see that when erupt, how much space. In the lower arch, we haven't done yet anything. Let's proceed further. I would like to show you some treatment phases, stage by stage. Now we have the premolar, the erupted. Let's see the lower arch. Next, you see the build-up in the incisors, and then next. Unfortunately, we have an impacted canine. One goes down in the arch and the other is still erupted, and therefore we need the surgery. Is the 2.3. Final phase of the treatment, and this is the end of treatment. As you see in this case, the arch development has been very effective. We compare pre and post, and we wonder why, in this case, the system worked so well. It did work well essentially because we had very constricted arches, and we had incisors that were retroclined, very constricted arches, I repeat, and the bone and muscles were favorable. And therefore, thanks to arch development, we could solve a severe crowding problem. Okay, next. This is a girl who is about 20 when she comes to our office, and she has this one occlusion. As you see, is a mild class 2, division 2. No space for the upper right cuspid. The upper incisors are retroclined, the central and lateral are out of arch, and we see crowding in the lower arch. Also in this case, as we are in a mild class 2, and I show you the head film and OPG. We are in a mild class 2. We have retruding upper incisor, crowding with a blocked upper canine. Treatment plan, arch development and class 2 elastics, because it's a mild class 2 and therefore with early elastics. Because you know what is good about passive self-ligation is that by using disarticulation and early class elastic, non-severe class 2 can be well treated from the very beginning. We correct class 2 already in the first phases. So early development with short elastic, we do not include cuspids because we have no space. We proceed progressively and we include the canine. We have good arch development. There is only one problem. At a certain point, the patient has protruded. Is too dental, dumping forward, as they say, and we have lip incompetence. Why? Because this arch development unfortunately caused pro-inclination excessive. So instead of developing laterally, this development occurred too much with protrusion. It was too protrusive. So what do we do? The picture doesn't show, it's not a 3D, and therefore if you had the patient in front of you, you could see how protrusive she was. Extracting? No, in this case we're not going to extract. Why? What did we do? We turned upside down the bracket on the upper cuspid so that we had a negative torque, and we had some IPR, and not in the upper. It was on all teeth, reduced IPR, and then using heavy elastics and power chain on the upper arch. Gradually, we succeeded in tilting the incisor in an acceptable manner, so good inclination, so no extraction, and we solved the case. In these cases, retention is essential. So in the upper arch, we used a fixed retention. In this case, Memotane is the best we have in nickel titanium. In the lower arch, Orthoflex Tech Reliance, which is really a very good system for fixed retention in the lower arch. This is the patient smiling. You see beginning and at the beginning and at the end of treatment. You see there is a slight incisal protrusion, but it's acceptable, I would say. And it's fine. Let's see another case. This is one of the first cases I treated with the passive self-ligation, so it goes back some years ago. This boy comes when he's 10. These are the arches, upper and lower arch. And this is the head film and the OPG. What are the problems here? We have skeletal class 2, hyperdivergent, so high angle, lip incompetence due to protrusion of the upper incisors, and we have a constriction in both dental arches, and we have bigger incisor and a slight contraction of the dental arches. So what are we doing? Passive self-ligation. So what do? Arch development. We start with non-extraction. We develop arches, some IPR to reduce crowding, especially in the lower arch. We try to reduce the size of the central incisor, and we use short class 2 elastics because the patient is high angle, so we want to use short class 2 elastics from canine to number 5. So we see the development of the arches is a good development, and we are in this situation at a certain point. Once again, we have protrusion, these teeth that dump out. So we have a head film, and we see what happens. We have this dumping effect. The teeth come forward, as we say, and it's no good. The mandible, the lower arch is not developing, it's not coming forward. This is typical of high angle, while the teeth inclined. So in this case, we have to be bold enough to explain to parents that we have to extract. And I learned the lesson. I knew it already, but I learned the lesson. When you do a treatment plan, and you know that there is a possibility of extracting, you have to say it immediately. So when you make the treatment plan, you have to say very clearly that perhaps you have to extract, so that there is no final surprise and no discussion with parents. So extraction of the 4 premolars, and with some classical biomechanics, extraction biomechanics, we land here. This is the final result. Fixed retention in the upper arch. And clearly the face is always high angle class 2, doesn't change, but the smile is nice. And we have harmony. You see the sagittal development at the beginning, after the non-extraction, and after extraction, before and after, smiling, before and after. And so, going back to initial data and records, how do we understand that we couldn't proceed without extractions? The skeletal and muscular problem, the muscles and a skeletal type like this, why do we have crowding? Because we do not have space in the arches for teeth to develop. We cannot have arch development here. If we want to really solve the problem, we have to extract. This is our patient with siblings, and we will come back to this picture at the end of the presentation. Okay, let's proceed with another case. Cases. This is what I'm going to show you today. This girl is, her mother is Thai and the father is Italian. Crowding. Number 23 is impacted. You see also on the left side we have crowding in both arches. This is the head film. We see protrusion also in the upper arch. Slight protrusion in the lower arch as well. And what is the main problem in this case? Crowding and dental class 2. These are the 2 problems that we have to face in this case. You see how much crowding we have and how much class 2. So in this case is when I see dental major class 2, I love to use the concept of sagittal first. So first we have to correct class 2 problems as early as possible using very heavy elastics when the patient is at the beginning and so is compliant. And if we can solve class 2 very early, the rest of the procedure is much simpler. This is my humble opinion. Therefore, class 2 correction and arch development to find space for all teeth. This, we used motion, and we bring molars into class 1, and then we start with arch development. So we place brackets and compressed springs, so gradually we proceed with arch development. Unfortunately, at a certain point, we go back to protrusion. The upper teeth are no longer balanced with basal faces that are dumping forward. And not only this, we still have a major space problem in the upper and lower arches, in both. What do we do at this point? Extraction. Yes. 4 premolars, and you see how almost automatically the face muscles, once that space is there, brings teeth backward. It does almost automatically, so muscles help a lot. This is a classic space closing mechanics with the help of elastics. This is the occlusion some days ago. I hoped I could close the case, finish the case, to show you the finished case, but we have some detailing. But let's say that the case is finished, but I cannot debond. This is the face. I took some pictures, and you see that we have reached good harmony. So tooth and face muscles are in good harmony, well balanced. This is the final head film. I made it just for you before coming, and you see that I show you the good axis, and you see that there is a good balance also from a cephalometric viewpoint. Let's see the initial records to understand why we couldn't proceed without extraction. The situation was such that we had to distalize because of the severe cluster. And I have some doubt. We always had doubt about the stability of distalization. And even if we distalize and we bring back to class 1 and we develop arches transversally, we do not have space for canine to erupt. It was an illusion. I hoped I could get it, but we see that there is a lot of crowding in the anterior, but also in the posterior segment, and therefore it's more crowding than we expected at first sight. Another case. This is our patient. She is now 13. She doesn't brushes very well, no good hygiene, full cluster, protrusion, crowding in the lower arch. Let's see head film. We have severe protrusion in the upper arch and the slight protrusion in the lower incisor, high angle. So we cannot expect much from growth. Class 2, incisor are proclined, overjet, crowding. In this case, there is no doubt. We have to extract. In this case, we decided to extract upper first bicuspid and lower second bicuspids so that we can correct class 2. This is the mechanic we use. First, we try to solve the lower arch crowding with the springs, coil springs, and then when we have a heavy arch wire, we have tied back to close extraction sites. Unfortunately, the patient is not very compliant, neither in terms of hygiene nor elastics, and therefore I use a device I don't like very much, but unfortunately I have to use because it really solves a lot of problems. So forces. Forsus is here. You see the end of the treatment where forsus, the patient who doesn't brush well. You see how gums are, and we see some side effect of forsus. So we have lateral flaring of upper molars, despite the fact that we use heavy rectangular arch wires, this happens with forces. So we should have a transpalatal bar when we use forces or similar devices. This is the case at the end of treatment. And you see how clearly the face is rebalanced. This is the final head film protrusion. The lower incisor have to be somehow protruded, because with the retracting mandible, if you do not have protruded incisor, you don't have overjet, and you will have lip problems. Before and after. You see lip incompetence is now solved, and this is after some hygiene, and you see that we have better cosmetic results. We continue with the other cases. So let's see this case of a young girl. She's 11, I think, more or less. Let's see the picture of the face, smile, profile, smiling. And let's see the arches. Just assess the case by yourself. This is the head film. So what are the problems? We have class 2, slightly skeletal, but a lot of dental. Class 2, we have lip incompetence, and therefore we have overjet, protrusion of the upper incisor, and a severe crowding, especially in the lower arch. Having made the previous experience that we discussed, and so I always have the doubt, extracting or not extracting, and they were based on my experience. I had warned the parents of this patient that I was going to proceed, trying not to extract, but perhaps I had to extract eventually. So treatment plan is class 2 correction with the approach sagittal first, and then probably I would have had to extract. So at the end of class 2 correction, I had to decide whether to extract or not. We have the distalizer. This is the result. We are now in class 1, and this is end of first treatment stage with motion. And at this point, we have to decide extraction or non-extraction. The patient has protruded incisor, lip incompetence is still there, and therefore the upper incisor have to be retracted. But as you see, there is a lot of space that we have gained in the upper arch, and the lower arch has some crowding, but with some IPR and transversal arch development, we can make it. So we proceed without extraction. IPR, we have our procedure. We see how we correct class 2. And let's proceed with the treatment. We start with all the classical mechanics that are typical of passive self-ligation. And you see what's happening, unfortunately. On the right-hand side, which was the one where we had a more severe class 2, there was a relapse. We relapsed in class 2. So this is something that may happen. I'll give you another tip. When you use distalizer, hypercorrect, because often patients relapse. So correction easily relapse. So hypercorrect. Perhaps I didn't hypercorrect enough in this case. Other pictures, because despite the fact that we closed most of the front spaces, retracted the incisors, we are always in protrusion. I'm not totally convinced I can make it without extractions. At this point, I would like to work together with the patient who is very compliant. She's really smart, and I decide to have a second distalization stage by cutting the distal arch, so distal to the lateral incisor, and using heavy class 2 elastics, so using once again a distalization of the lateral and posterior segments. And as you see, it worked. It worked. And the girl is really very compliant. And also the brackets in this case were turned upside down because we want to reduce torque. So we turn upside down, we reduce torque, we distalize cuspids, we gain space, and we have a good balance, good harmony. You see how the patient smiles. What is important is that patients are not dumped out, are not pro-inclined. I don't like it, it's horrible. While you see,
Ecco, torno a vedere, vediamo I records iniziali.
We see the initial records.
Perché qui ce l'abbiamo fatta?
Why did we make it? First, because the face type is very different from the previous one, who was a high angle with very weak muscles. Here we have a different face type from a skeletal and muscle viewpoint. Crowding in the upper arch is not so severe, so we can gain space. Crowding in the lower arch, thanks to IPR, can be obtained because we have of course, a Bolton discrepancy when we have these cases, and therefore with good compliance we can make it. So let's see this boy. He's a younger boy. He's 9 when it comes to our practice. This is the occlusion when the patient comes to see us. Class 2 on both sides, more on the left than on the right. Crowding, constricted arches. For sure, they are constricted. You see class 2, it's a really skeletal class 2. And you see the usual problem of molars impacted in the back of the deciduous molar. If we can act early, we can distalize the 6, but it's too late, and they're already erupting in the arches. So let's start with the treatment plan. Arch development, because we have seen that the arches are constricted, is not severe, is not particularly hyperdivergent, and therefore we think that we can proceed without extraction. But after some arch development, we realize that space is really not enough, and especially in 2.5, we are in a poor condition because 2.5 is still impacted. You see OPG, we do not have space for 2.5, and in sector 1 we still have some crowding. We see that 2.5 is not well formed, and there is no development possibility. It cannot erupt, is a lost tooth, as we say. Therefore, we extract 2.5 that is impacted, and also 1.5 is extracted. And therefore, in this case, we extract only in the upper arches, both 5. I do like to extract because in class 2 patients, extracting the lower arch is not always very easy. It always causes problems. If you succeed in not extracting in the lower arch in class 2 patients, it's much better. So development in the lower arch with IPR, and this is end of treatment with the classical class 2 occlusion, molar class 2, canines class 1. And I think that we made the right decision. However, the patient will always remain skeletal class 2. Another case. I still have 5 minutes, so I have to rush. Sorry for you. This girl is 10, 11 when she comes to see us. Lot of crowding, no space for upper cuspids, and they tend to be impacted. You see slight impaction, constricted mandible, big nose, unfortunately. Some arch development, but you can already see from this picture that we're not going to gain space, and therefore we decide to extract upper five. And we do it when we wear rectangular arch wires. We have buttons on 5s and 6, class 2 elastics, and cuspids erupt well, build up, so always used, and this is end of treatment. So, you know it, but when we extract only the upper arch, the molar relationship requires a different inclination, a different tipping of the first molar. That has to be less tipped, 0 tip instead of -5 that we usually have in normal straight wire brackets, and so also in self-ligating brackets. Furthermore, we need the mesial rotation of 6 because they have to take more space in the arch. And therefore, we should have 0 distal tip on the bracket. So what do we use? Second molar tubes, and we place them this way, and this applies also to 6 and 7. So we have 0 tip and no rotation. No distalization, no distal rotation. They're slightly tilted forward so that the molar is more distally tipped or more distalized. So I have to skip some cases because I have only 4 minutes. So I proceed. I skip this case. Unfortunately, it was a nice case, but I have no time. So the last 2 cases, I'll show you a case where we extract 4s, and then I will end my presentation. This is a patient. He's 10, late mixed dentition. He has lost 1 cuspid in the upper arch, naturally, and the lower arch, I don't know whether they were naturally lost or were extracted, class 2, but good development type, as you see. You see good symphysis, good mandible. This is when we start the treatment. Here's a case, and at this point I decide immediately to extract the upper and lower canines because I don't like to distalize too much, and there is no space. It's a severe case. I didn't trust the patient, not very compliant, because it's a special family. I will tell you why. So we extracted 1.4 and 2.4, some IPR in the lower arch where we had some crowding, class 2 elastics, and this is the final result. It's a special family. Why? Because they didn't allow me to have the final radio X-rays. The mother is a pediatrician, is somehow an alternative doctor, and therefore it was very difficult to manage the case. And she said, no X-rays, I don't want too many X-rays for my child, so I cannot show you the final X-rays, but you can see from the face pictures, face photos, that the extraction didn't cause any problem to his smile line and to his face. I would like to finish with this rapid case where I extract a lower incisor. I hate extracting lower incisor because always causing some problems. I have bolt-on discrepancies, overjet, overbite are not harmonious. But if there is a bolt-on discrepancy, like in this case, that is quite severe because you see no crowding in the upper arch, so in the lower arch, and we have crowding in the upper arch, so therefore we have bolt-on discrepancy if it's a class 1, so we extract a lower incisor, and in this case, this is the ideal solution because you see that finally we have a good result. Also in overbite-overjet relationship. Okay. So you see this picture that I show at the beginning of my presentation where the boy on the right-hand side is the patient who had 4 extractions because of excessive protrusion. Look now how broad is his smile, and the other are siblings. They're all my patients. He's the youngest patient, and then we have the elder son, brother, 4 extractions also, and the sister, non-extraction treatment, and he had extraction treatment. And I don't think that their smiles are typical extraction cases. They are not penalized because usually there is this saying that you have darker corridors, poor smile if you extract. This happens if you extract where you should not extract, but if you do it well, if you choose the right treatment, you extract only when you need to extract, I think that extraction can be a good system to solve major crowding problems. Statement, extract for the face and not for the space. I would like to change and say extract for the face and sometimes, and more often than you think, even for the space. This is my final statement, how I would change it. And with this, I would like to conclude, and I thank you very much for your kind attention.